options right now. One is a 26-year-old female who, hold on, let me see this here. So we have either a 26-year-old female with abdominal pain and she's pregnant, or a 45-year-old male with left-sided abdominal pain. So you guys in the chat, you can say which one you want, and I'll give it like a few minutes, and then just remember that I haven't seen any of these, and remember that I'm just a resident, so I don't know everything. Okay, so it looks like everybody wants the okay, and then on YouTube as well. I'll give you people on YouTube a few minutes to decide what they want to do. All right. So on YouTube, let me see if I can pull it up. All right. Okay, and so what we will do is there's going to be a link to the actual case that's going to be put up. I think we're going to do the female, the 26-year-old female who's pregnant with abdominal pain, and so you can follow along. What I would recommend actually for the people on YouTube is if we can, if for whatever reason the what is here is not working. You can always go to YouTube and just stream it as well, and have and basically follow along with the stream there. You just have to mute it. Whatever it is that you guys want. This is all kind of a work in progress, really. Okay. So again, I haven't seen this case before. I don't know if it's going to be applicable to our rounds. And if it is, then great. If not, then you'll learn something else. All right. Are you guys ready to start? If anything happens, if the audio goes bad or you can't see anything on the stream, you just let me know. Cool? Cool. All right, so we have a 26-year-old female who comes to the office because of a 3-day history of lower abdominal pain. So low abdominal pain. She's 18 weeks pregnant, so that's obviously going to be important. The pain is sharp, steady, radiating across her lower abdomen bilaterally. So the way that it'll work here is I'll ask you what you guys think. You can either type it in the comments or you can just talk. I would prefer probably people just to talk. It'll make it easier on me. So so let's finish this and then I'll ask what you guys think. So last night she developed new nausea and vomiting. She's not been able to keep down any food or drink this morning. She had a normal bowel movement yesterday. She says she felt cold and shivering this morning, followed by feeling warm. However, she did not check her temp. She denies vaginal bleeding. So right off the bat, we have low abdominal pain. She's pregnant. It's sharp, steady, radiating. She has nausea and vomiting. Can't eat. She did poop, so it's not like she's constipated. She has some chills and maybe a fever, so plus or minus a fever, and no vaginal bleeding. All right. So who wants to take a stab at what they think is maybe going on? Like what are some of these symptoms telling us? Dr. Noon, do you want to try to give it a try?
Yeah, I can try.
Okay.
So, just like you said, if she's pregnant, then obviously there can be something going wrong in her reproductive system if she's hurting so much. And you said how many weeks she's pregnant?
It looks like 18 weeks.
18 weeks. Okay, so there can be like with pregnant, there can be many different issues. We can quickly like order ultrasound to see if the baby is fine or if she's having some internal bleeding or placenta breakage or anything that leads to a miscarriage or something. Because if she's not constipated, then there is not maybe not wrong anything with her stomach or something. It's basically it can be something wrong with the uterus uh, or the baby's issue going on.
Yeah, definitely. So it looks like that the focus on the baby is actually pretty important because she's having a lower abdominal pain. And so with the lower abdominal pain, what are the structures in there? We have the uterus, we have the ovaries, right? So ectopic pregnancy, though she's 18 weeks, an ectopic pregnancy at this point would probably have ruptured, depending on where it was. If she had an injury or something like that, maybe she hit her belly like a car accident, although I don't know. It doesn't say anything about trauma. So like you're saying, a placental problem within the uterus. In the right lower quadrant, what else is there?
Ovaries are there.
Okay.
So there
ovaries.
can be some like torsion in ovaries or
yeah.
the fallopian tubes or if we said if there's ectopic pregnancy, fallopian tubes can get swollen and causing the pain or something. And maybe the baby needs to be removed if she wants to save her life or to see what else can be done to save the baby too.
Yeah, that's definitely a good thought. What about non-gynecologic? Is there anything else in there that we can be thinking of?
Yeah, appendix.
Appendix. You also have your ureters running through that area. Good. All right, and then you also have all your muscles and everything like that too. Although she's having nausea and vomiting, and so the nausea and vomiting looks like it's preventing her from eating or drinking anything. So if it were musculoskeletal, it doesn't seem likely to be musculoskeletal. It actually seems more intra-abdominal because it's causing this nausea and vomiting. All right. Good. Anybody else want to give it a try? Anything else they want to add?
If well, first we should check if she has a fever, because the chills and like being slightly warm may suggest that there's some sort of an infection happening, or like something that would cause the inflammatory response.
Yeah. So exactly. So we have a potential. She's saying she has chills, and whenever somebody says chills, and like, let's say they don't check their temp at home, I assume until we prove otherwise that they are having a fever, and so maybe this is an infectious problem going on. It can also be inflammatory, right? So rheumatologic or autoimmune problems tend to flare up in pregnancy. So it's possible that this can be autoimmune as well. It's kind of like that idea of keeping your differential broad and narrowing it down after that. All right. So what do you think about something like diverticulosis or diverticulitis? Do you think that's possible in her?
I don't think so. She will have diverticulitis or diverticulosis because of the age. Diverticulitis and diverticulosis occurs in a like late age disease actually.
Yeah. So what will make you more prone to having diverticulosis or diverticulitis?
Constant constipation, less a nutrition which has less fibers.
Yeah. So it's that idea that you're putting more pressure on the bowel wall. So for people that don't know what diverticulosis or diverticulitis is, it's basically in your colon. So if this is your colon here, when there's a lot of pressure in there, a lot of times because of constipation, you're pushing on the bowel wall, and that causes these outcroppings outside of the colon that make it a little bit easier for like food and stuff to get stuck in there. Make it easier for food or poop particles to get stuck in there. And whenever something gets blocked, you're more likely to have an infection, right? And so that's when you get diverticulitis, so infection of those little outpouchings of the colon. And so she's having abdominal pain that is in the lower abdomen. Typically, we will see diverticulosis or diverticulitis in that lower left quadrant. It's not 100%. You can get it at other parts of your colon, but a lot of times we do see it in that left lower quadrant. So it is possible, though, given the age, you have to have this constipation or these processes for a very long time. And so a 26-year-old is not likely to have diverticulosis. Possibility, but not likely. So it would be lower in our differential. What about gastritis, Dr. Buchanan? What about gastritis or an issue with the stomach? Do you think that would cause her symptoms?
That may cause the vomiting, because gastritis is like inflammation of the stomach, right?
Yeah.
So that could have caused like the nausea and the vomiting, also the chills and the fever. So I think it's possible, but also she says that she's more having lower abdominal pain, and the stomach usually, like if it was in the stomach itself, that would usually be more upper abdominal pain.
Yeah.
So I wouldn't rule it out, but it doesn't seem as likely given the fact that it's lower.
Yeah, good. So position is super important. She's complaining mostly of lower abdominal pain, but let's say it's not gastritis. Let's say it's gastroenteritis. Let's say she ate something that made her sick, and now she's having nausea and vomiting, and she's starting to cramp lower down. And that's a possibility, but without diarrhea, less likely. So, but it is possible. There is a way to connect it. So I wouldn't rule it out 100%, but it's gonna be way lower on my differential just because of what you said. The position of the pain is different, right? A lot of times, gastroenteritis doesn't really cause a specific pain in one part of the belly. A lot of times it'll cause more generalized pain and cramping. So good job. All right. So what else did we miss in there? Anybody else want to bring something else up from the HPI?
I want to see what's the past history, if she was using any oral contraceptives previously, or she has any previous miscarriages.
Yeah, so I do too. I don't know what exactly is her history yet, but I think we're gonna get it. So, is there anything else that anybody wants to talk about from the HPI? I don't think that there necessarily is. shivering. No, I think we got pretty much everything. All right, so we're saying that this might be a gastrointestinal problem. We're saying that it might be a gynecologic problem. We're saying that it can maybe. Oh, what about genital urinary? Does anybody think that this might be like a GU problem? Like Dr. Desai, you're saying maybe like a UTI. And then Dr. Pulido is saying concern for appendicitis or spontaneous abortion, definitely. The one thing that would kind of argue against maybe a spontaneous abortion is that she hasn't had vaginal bleeding, but you can have an abortion with a closed cervix and you're not having any of that blood come out. And so that would be, I think it's like a missed abortion, is what it's called. So, okay. So yeah. So, Dr. Desai is saying their mic's not working. UTIs, you can't get in pregnancy. Would a UTI itself cause nausea and vomiting?
No, I don't think so. It will cause nausea and vomiting.
Yeah, probably not. Yeah, but maybe a kidney stone. Dr. Desai is saying maybe a kidney stone. Dr. Hanin, what do you think? What else can maybe cause that? All right, so they said maybe a kidney infection, which is also something I was thinking of. She's having fever, she's having chills, she's having nausea and vomiting. Even in a non-pregnant patient, something like pyelonephritis can cause her symptoms. But her pain is located in the lower abdomen, so that's kind of one thing that I'm thinking maybe not, because it's not radiating to the back or anything like that, and it doesn't. I don't think they're saying it's radiating to her groin. They're saying it's sharp, steady, and radiating across her lower abdomen bilaterally. So, all right, we'll see. I think. Okay. Oh, Dr. Arthi, can you explain what you're saying over there?
Yeah, sorry, I was unmuting my mic.
It's okay.
But generally with like pelvic inflammatory disease, it's an infection of the upper female reproductive organs and occurs almost exclusively in like sexually active women. So
Yes.
if she is currently still sexually active, that might be reason for her infection and lower abdominal pain.
Definitely. So if she's having lower abdominal pain, I mean, we know she's sexually active. We don't know because she's pregnant, but we don't know if if she's had multiple partners. We don't know her sexual history, so that's going to be super important to know. The other thing we would want to maybe ask is, they say no vaginal bleeding, but does she have any discharge? Has she noticed any like genital lesions? We'd want to take a look at that as well. Okay, good. All right, let's move on to the next part of the case, so the review of systems. Okay, so review of systems show that the patient generally feels weak and ill, but is in her usual state of health until 3 days ago. She's gained approximately 5 pounds in the pregnancy so far. That seems like an appropriate amount of weight gain during her pregnancy. So it looks like before all this happens, she's probably doing okay. There's no rashes. Her mouth feels dry. No headache, nasal congestion, or sore throat. No cough or shortness of breath. No chest pain, palpitations. Has had a decreased appetite for a day. Not able to keep any food or drink down because of the nausea and vomiting. Has not had diarrhea or constipation, so it looks like her bowel movements are generally okay. She has a frequent urge to urinate and a sensation of an incomplete bladder emptying for the past 3 days. No dysuria or hematuria. She's G1P0A0, so this is her first pregnancy. She's never delivered a baby. She's never had an abortion, and she's been seeing an OB for all routine visits and testing. No vaginal bleeding. She has diffuse low back pain, no muscle aches, neuro and psycho non-contributory. All right. So we already talked about that her pregnancy maybe is going okay so far. What else do you guys think? I'll actually call on people. So Dr. Steele, what are you thinking about her review systems?
Well, I was personally considering appendicitis, mainly because personally my sister's had it, so I saw a lot of the similar symptoms. Since she couldn't keep food down, she's been having nausea, fever or potential fever, and then all of those are typically signs of an infection. And since it's lower,
So let's think about appendicitis for a sec. I definitely agree. A lot of times you'll have nausea. A lot of times you'll have vomiting.
Mm-hmm.
What is another symptom you typically get with appendicitis? I don't know if your sister had it.
Yeah, she did. She ended up having to get her appendix removed, but.
Oh yeah, but like another symptom that she might have had.
Besides pain down there, she was having excruciating pain.
Did she have any diarrhea?
I don't believe so. I don't remember. It was a couple years, maybe.
No, it's okay. It's okay. So a lot of times with appendicitis, when I see it in kids more so, there a lot of times there is some diarrhea. She doesn't have diarrhea, but that you can't rule it out completely.
Yeah.
To have diarrhea, right? So I agree. It looks like she's in a lot of pain. She's maybe having a fever. She's definitely having chills. She's having pain in the lower abdomen. Appendicitis, it depends on how bad it is. It can cause more generalized pain, especially if you have a rupture. But typically, we will first see appendicitis start at the belly button. So when it first starts, they'll have pain around the belly button, and then migrates to that right lower quadrant. Having said that, I've seen plenty of kids with no pain, and they just are not eating, and they have this really bad-looking appendicitis. So kids in general, this doesn't really pertain to the case, but kids in general can have very strange presentations for appendicitis. So if you any future pediatricians out there, that's going to be something you're going to keep in the back of your mind.
Question.
Yeah.
Since she's pregnant, would it affect where the pain is located? Like, would it move up a little bit? I believe you mentioned something like that in one of your videos.
Potentially. So the reason why is dependent on the size of the uterus, right? So an 18-week uterus is probably right below the belly button. So you're not having this big gigantic mass that's pushing everything up yet. And so everything would be more or less in the same position. And so I would expect an appendicitis to still be in that lower abdomen. Versus if she was 38 weeks or 40 weeks, that appendicitis might be felt a little bit higher up. Does that make sense?
Yeah, got it. Thank you.
Cool. All right. So, Dr. Asya, you're saying you're asking about a hernia.
Yeah, so I thought it might be a hernia, but also that doesn't make sense because it's usually on one side, I think, but I just wanted to see like maybe that's a possibility.
It is. So, so with hernias, so if you have a hernia that's just kind of poking out, it doesn't do anything, right? What is going to cause pain and cause issues is when that hernia that's poking out gets incarcerated, right? So now you have the little hole that it goes through, you're getting stuck in there, and it's squeezing off that blood supply, and that bowel will end up dying, right?
Yeah.
And so it is possible that she might have a hernia. We'd want to take a look at her physical exam and see if we see anything. And so that's actually a really good thought. But it would probably be, she would probably mention it, in the beginning, like, hey, yeah, I have this bulge that's hurting, right?
Right.
So I mean, you don't want to write that off because there's a lot of times that I've seen patients and they tell me all these different things and they say, yeah, my foot is turning black. And I'm like, wait, why didn't you say that first? So stuff like that happens. And so you never want to write that off. But yeah, I would definitely keep it on my differential, maybe a little bit lower because we would probably see it or we would probably have heard about it by now. But, I didn't write these cases, so who knows? Okay. All right. So Dr. Dunker, what about, you guys are talking about the urgency, the urge to pee. Can you explain your thought process there? All right, let's try Dr. Orselli.
Do you mind repeating the question?
Yeah. So there was mention that this the frequent urge to urinate might be a symptom of her what's going on. That maybe that this can be a like a UTI or something like that. So what is your thought process behind that?
I mean, it would make sense if it was a UTI because she would have the discomfort and pain in her lower quadrants.
Okay.
Mm,
So where's the bladder located?
like in the middle of those two quadrants.
So
Like behind
yeah, exactly.
the uterus.
Exactly. So you have the bladder kind of sitting up front, and then you have the uterus behind it, right? As the uterus grows, you're pushing on that bladder, right?
Mm.
And that's going to make more pressure on the bladder, and that's why pregnant women think that they feel like they need to pee all the time because there's less space, there's more pressure on it, you're triggering that sensation that you need to pee. She's 18 weeks, so that uterus is not as big, but it can start pushing on that bladder. So it is a possibility. With the UTI, you typically will have pain, right? So you'll have some dysuria. You'll have a burning sensation when you need to pee, though, it doesn't happen all the time. There's a lot of pregnant women that have bacteria in their urine. They just don't have that inflammation to cause the pain. So definitely a possibility. I would say with the nausea, vomiting, fever, urge to urinate, I would probably have a urine infection a little bit higher on my differential. The no dysuria and the hematuria are kind of what maybe brings it down a little bit more, but I wouldn't take it off completely. And then I think you mentioned pregnancy-induced diabetes. So what is your thought there?
I only know this because it's happened to a relative. But basically, she got diabetes from her pregnancy, and so she kept urinating a lot, and then she just had to keep her blood sugar in check.
Yeah.
Because I think she was at risk. If it was like continuous, she might get like diabetic ketoacidosis, something.
Yeah. So that's a good point. DKA or diabetic ketoacidosis can cause pretty severe abdominal pain, and you'll have some nausea and vomiting, and people can come in altered. They're breathing really fast, and so if she has DKA and her if this is a new diagnosis of gestational diabetes and it's very uncontrolled, or if she had diabetes in the past and she's just not controlling her blood sugars, then yeah, you can definitely get DKA. So that's a very good point that I actually didn't think about until you put that up. So good job. Okay. All right. Let me see on YouTube. Dr. Walsh on YouTube is saying, could it be a kidney infection from a UTI? So yes. Ovarian cysts are a possibility, especially if you have a ruptured ovarian cyst. All right, I think we answered all those. Cool. Anything else in the review of systems that anybody wants to bring up? What about the dry mouth? That one stood out to me. It looks a little weird.
Could that also just be because she hasn't been eating and hasn't had any fluids lately, so she's probably really dehydrated?
Yeah, that is true. She might just be dehydrated. That's actually probably more likely. I don't know. I was starting to think autoimmune for a second, like Sjogren's syndrome, but that doesn't make sense. You're probably right with that. It's probably just dehydration. Okay, I was trying to get too analytical with this. All right. Dr. Desai saying any chances of sepsis? Yeah, probably, or maybe we just have to take a look at the vitals. DKA can cause dry mouth as well. I think it can. I'd have to look that up, but I think it can. It makes sense. DKA is very dehydrating, so yeah, I'm sure it can. And also, I forgot, she's vomiting a lot, so that also goes to explain why she's maybe dehydrated. Okay. All right, I think that is. Oh, Dr. Sexton on YouTube is saying dry mouth is also a symptom of gestational diabetes, which is actually very true as well. So you have with diabetes, you have that polyuria, polydipsia, polyphagia. So you're peeing a lot, you feel like you're really thirsty and drinking a lot, and then you want to eat a lot too. So inflammatory bowel syndrome, or no, IBS. So sorry, irritable bowel syndrome. So yeah, that definitely can cause lower abdominal pain, and you probably can flare with that. All right, so I think we have enough of the review of systems, unless anybody else wants to say anything about that.
I had a question.
Yeah.
About gestational diabetes. Does that go away after pregnancy, or it just stays and turns into a different one?
Yeah. So a lot of times it will go away, but you're at higher risk of developing diabetes after pregnancy. And I have patients that develop gestational diabetes, and then they have they're not able to control their blood sugars afterwards, and we have to kind of start them on metformin after they deliver. So yeah, a lot of times it will go away, but you are at a higher risk of developing diabetes after that. Okay, good question.
Okay, thank you.
No problem. All right, so anything else in here before we go on to the past medical history? Yeah, so IBS, there's a little conversation here saying that it usually comes with diarrhea or constipation, not vomiting. That's true. What about, would it cause her abdominal pain? But I was thinking like cyclic vomiting syndrome. Maybe she smokes like marijuana. That can cause a lot of vomiting. Although I don't know if it can cause abdominal pain. She wouldn't necessarily have a fever. So yeah. Anyways, it's probably less likely. All right, let's go on to the past medical history. All right. So she has a past medical history of mild intermittent asthma diagnosed in childhood, requiring only occasional rescue inhaler, no hospitalizations for asthma, otherwise healthy. Wisdom teeth removes, probably not important. Albuterol inhaler is needed once a month. She takes a daily prenatal. That's a good point. Does she drink? I've had pregnant women who drink, so it's a possibility. So no drug allergies. Mom is healthy at 50. Father is 53 with high blood pressure. She has a social history here. So she's an engineer. She exercises 3 days a week. She drinks 2 glasses of wine per week, but stopped when she found out she was pregnant. Does not smoke or use any drugs. Has not had any recent travel. She's monogamous with one male partner. Okay. So anybody want to take a stab at her history? Is there anything in there that's really pertinent? All right. So, Dr. Zhang, do you want to talk about what you just said?
I said it was mostly not chronic since their lifestyle is quite healthy. When her family passed, there's like nothing significant that could cause like something chronic, most likely.
And she might be a little bit at a little bit of a lower risk with that family history. Yeah, her lifestyle seems pretty healthy. Yeah, I'm not really seeing anything either here, but I like that point that it's probably more of an acute problem versus a chronic disease. So that's good. All right. Anything else that anybody sees? Maybe due to the fact that she's exercising 3 days a week is a factor. And potentially, it depends on what she's doing. So, like, if she's ramping up her workouts because she's gaining 5 pounds from her pregnancy and wants to keep the weight down, one, that's not advisable, and two, if she's like doing weights or she injured herself while exercising, she might have had like injury to the uterus, like or like the placenta. Without vaginal bleeding, though, probably not as likely, but it'll be something we want to take a look at on the physical exam as well. And she has lower back pain too, so that's true. All right. Anything else that you guys want to think of? I think we talked about pelvic inflammatory disease. So whoever had mentioned that, do you want to talk about why that's more or less likely now? Dr. Farida, do you want to talk about that?
Yeah, when someone brought up the pelvic inflammatory disease, you mentioned something about the number of partners she was having.
Yeah.
And in her history, if I heard you correctly, you said it was only one male partner. So I think that would make it less likely because she's pregnant, so she's been like with the same male partner for a period of time. So that would, I don't know.
Yeah, so definitely true. But so we have her sexual history. Do we have her partner's history?
Oh yeah, no, that's important.
That's important too. But I mean, a lot of times we're not going to ask that. We're just going to assume like, hey, they're probably doing okay. So I would probably say a little lower likelihood. But if we see on the exam just like purulent discharge in the vaginal vault, or like any lesions on like the vagina or on the vulva, then I would probably think like, yeah, maybe we should talk about the sexual history from the partner. But yeah, all right. Cardinal ligaments can be stretched, but she is high estrogenic state, which will make her ligaments relaxed. That might cause some abdominal pain. So Dr. Buchanan's asking, could asking if she's married or how long she's been married help? It can, but it's not 100% because you never know how that relationship is, even if they're married or not, and you don't know kind of what sexual partners or whatever it is that they have is going on. And so I would probably ask a little bit more about her sexual history, like maybe any history of like STIs, or if she, I guess if they're currently sexually active, or if she's sexually active right now, that would probably help too. Okay. I don't think that there's anything else. Her asthma is pretty well controlled. She hasn't been hospitalized. I don't think asthma would necessarily cause abdominal pain. No real meds that she's taking. Yeah, so I think we're good here. We can probably move on to the next thing, which is physical exam. All right. So, well-developed female, appears tired and ill, but no impaired distress. Her vital signs show a temp of 38.8, pulse of 120, BP of 110/76, and respiratory rate of 20. So let's see here. I'm gonna call on somebody to interpret those for me. Okay. Dr. Fatima. Dr. Fatima Sharara, can you interpret those for me? Okay. Dr. Christina Nguyen.
Hi, yeah, so her temperature is definitely really high. If we convert it to Fahrenheit, then it's like 102-ish, I think, and that's definitely a fever like we were suspecting earlier. Her pulse, oh, sorry.
What was it? Sorry, what was 38.8?
0.8.
Yeah, is that 102? It's elevated. I didn't really, yeah. So you're right.
Yeah. And then her pulse is above 100. It's 120, so that would be tachycardic.
Mm-hmm. Yeah, so she's tachycardic. She has a high temp. What else?
Her BP and respirations look normal, I think.
They look okay. If her blood pressure, you always want to make sure that you look at the past. Like blood pressures, honestly though, 110/76 is pretty good, especially for a pregnant lady. A lot of times in pregnancy, your blood pressure will be a little bit lower. So yeah, that looks pretty good to me. So we have an elevated temp, we have an elevated pulse. Do you think that she is septic?
I'm not sure, but I would guess yes.
Yeah. So sepsis criteria or SIRS criteria. So SIRS stands for systemic inflammatory response syndrome. So it just tells us that there's a good amount of inflammation that generally is pretty it's like body wide, I guess is a decent way of putting it. Basically, you have systemic inflammation because of some ongoing process. And so there's 4 things you look for. You look for an elevated temp. You can also have a lower temp, but for the sake of this, we'll just go with elevated. Elevated temp, pulse above 90, so she definitely qualifies for that. Respirations above 20, so she's 20, so I probably wouldn't. I don't think I would count that. And then her leukocytosis, so a white blood cell count above 12,000, I believe, is the 4th one. So you need to have 2 of those 4. And for her, she already qualifies, so she has elevated temp and pulse. So that she qualifies for SIRS, so for that systemic inflammatory response syndrome. Aside from that, going a little bit further to sepsis, you have to have SIRS plus a source of your infection. So you have to be able to say, yeah, she is in an inflammatory state because of this ongoing problem. And so we don't know what that ongoing problem is as of right now. We're still trying to figure that out. So I would say that she meets SIRS criteria, and we're going to be looking for a source of infection. So good job, Dr. Lin. All right. So she feels hot, diaphoretic, no skin, or no rashes or cyanosis, dry mucous membranes, no scleral icterus or conjunctival injection, neck supple, no adenopathy, breath sounds are okay, faint inspiratory crackles on the left side, heard at the base, no wheezing. Okay. She's tachy, regular rhythm. She doesn't have any swelling in her legs. All right, so GI. So bowel sounds are normal. Abdomen soft, diffusely tender on the lower abdomen bilaterally, with no guarding, rigidity, or rebound. No tenderness in the upper quadrants. Gravid, non-tender uterus, 2 centimeters below the level of the umbilicus. No inguinal or femoral hernias. So whoever mentioned hernias, good job thinking about that, but it looks like it's probably not a hernia. Rectal exam, non-tender, stool brown, heme negative. I don't know why they would do I guess I can yeah. All right, GU, normal external genitalia, no cervical motion, tenderness, scant, thin, white discharge from the cervical os, which appears closed, fetal heartbeat regular at 150 beats per minute, no swelling or tenderness or deformity in the joints or extremities, positive CVA tenderness bilaterally, unremarkable neurologic exam, and she's alert-oriented, fluent, and coherent speech. All right, so there's a lot there. Dr. Amanda, do you want to take a stab at this? So what stands out to you the most? All right, Dr. Brown, what stands out to you?
I was thinking the faint white discharge from the cervical OS. And then someone else in the chat mentioned the tenderness too.
Yeah.
Of that region.
Yeah. So okay. So the discharge, scant discharge, whitish color. A lot of times that can be normal in pregnancy. It can be normal in non-pregnant people also. So I don't know if I would be too concerned about that. But it is definitely something to think about. If you have like purulent, like it looks like pus coming out of the cervix, a lot of times that's like gonorrhea, and especially if the cervix looks like red and inflamed when you look at it on a speculum exam, you can say like, yeah, maybe that's an STD. Chlamydia a lot of times looks like a thinner, clearish, pretty copious discharge, and a lot of times they will have some redness of the cervix as well. This one looks okay from what they're saying. And then you said CVA tenderness is the other thing you were thinking of?
Yeah, because well, like they're saying in the chat about the kidney, but I also would think that would go along with the sepsis because the infection could be like either centered around the kidney or like your urinary bladder, and so that could be like a source for the sepsis, which is the fourth criteria we need for the SIRS.
Yeah, exactly. So she might be septic because of a kidney issue. So CVA tenderness bilaterally, I mean, if this is her kidneys, that sucks. It's probably both her kidneys are infected.
Yeah.
And for anybody who doesn't know what CVA tenderness is, basically you're on your back, so like right where your lower ribs are. I don't know if you guys can see that, but on the lower part of the ribs, that's where your kidneys sit. And so I put my hand on their back, and so I put my hand on their, it's probably a better way, on their back where the kidneys overlie, and I tap on my hand to kind of to hit their back. And if they have inflammation of the kidneys, they will jump up. They will say that it's extremely painful. They'll kind of swat your hand away, or they'll say, ow, stop it. And so if she has it bilaterally, that tells us that, she probably has a kidney infection. Let's say she wasn't feeling any fever, and she was having blood in her urine. What else would you be thinking of? Dr. Anish, what else would you be thinking of?
I'd probably be thinking of some sort of kidney injury. Unless she's said specifically, I wouldn't think it's physical, like she got hurt physically, but I would probably think about some sort of like bodily, like biologically or molecular kind of like compound obstructing it.
Yeah, possibly. Like you have if she had some type of injury, she could have like a kidney laceration or something like that. I mean, without the history of it, probably not, but who knows? Dr. Sexton is saying on YouTube that possible kidney stones. What do you guys think about that? Dr. Urselli, you're saying maybe kidney stones too.
I just came to that conclusion because you mentioned blood in the urine, and we know that she's got like abdominal pain. Yeah.
So if you have the CVA tenderness, you have blood in the urine, and let's say no fever. It's not this patient, but hypothetical. Yeah, I would definitely be thinking of a kidney stone. That stone, as it travels down, is going to basically induce some trauma on the ureters or wherever it's passing through. That can cause some blood as well. So definitely, for her, she doesn't have blood in her urine. She does have a fever. Less likely. Also, kidney stones, typically you'll see them on one side versus the other, on both sides. And the reason why is because kidney stones come from the kidneys themselves. So it's very uncommon for both kidneys to make stones at the same time. It's possible, but less likely, because you have to make the stones. It'd have to be both traveling down at the same time, and less likely. Versus a infection starts outside. It starts in the bladder and travels up. So if you have a bladder infection and it travels up on one side, there's nothing stopping it from traveling up the other side. So a lot of times you will have some of that bilateral pain. I've actually, for me, in my practice, which is not very extensive, I've seen more so unilateral pyelonephritis, but that's not to say that bilateral isn't as common, if not more. So, good. Dr. Desai is saying, is the uterus blocking the kidneys? Probably not. Not the kidneys. Maybe the ureters. I have to remember my anatomy, but if it gets big enough, No, because you're gonna have. I mean, pregnant women all the time don't have severe kidney injuries. So if you have blockage of that, you'll probably have backflow of the urine. You'll probably have some kidney injury, and we don't really see that often in pregnant women. So that's a good question, though. I'd probably look into it and get back to you. Okay. All right. Anything else in the physical exam? The dry mucous membranes tells us that she's probably dehydrated. Can a viral infection lead to kidney disease and CVA pain? Most likely not, because the viruses have to enter through some orifice, right? So a lot of times we get viruses in our respiratory tract because they come in through our mouth and our nose. It would be very difficult for a virus to enter the bladder, then travel all the way up to the kidneys without causing other symptoms. I don't think I've ever heard of a viral kidney infection. If you guys have, that'd be super interesting. Dr. Safa, you're saying left-sided inspiratory crackles are something to be concerned about. Can you explain your process there? Because I was wondering about that too. Just on the left side at the base, I would say without any respiratory symptoms, no wheezing. She does have a history of asthma, but no wheezing. My thought process behind that is maybe she has pneumonia. I doubt it because of no cough and no other symptoms of upper respiratory infection. A lot of times as the belly grows, you start to put pressure onto the diaphragm and you're not taking those deep breaths in as much. And so that can cause those lower lung field areas to be more static. They're not moving as much. And so you can have an accumulation of fluid there. It's like an atelectasis maybe, but I don't think there's an infection, maybe potentially, but less likely because she wasn't really complaining of anything else. So I'd probably just keep an eye on it. All right. Dr. Sanola saying, would that show infection? Possibly. We don't know. If we were concerned enough, we would probably get an X-ray to see, or actually you can get a ultrasound and see as well. But my suspicion is probably a little bit lower. Dr. Sexton's asking, would appendicitis cause flank pain? Would it only be on one side? Yeah, most likely, if it is going to cause flank pain, it would probably cause it on the lower flank, on the right side, not so much on the left side. But good question. All right, let me see if there's anything else in the history. All right, she is diffusely tender across the lower abdomen bilaterally with no guarding rigidity or rebound. So that tells us it's probably not something perforated. So a gravid uterus that's non-tender 2 centimeters below the level of the umbilicus. Anybody want to tell us, try and say what that means?
Did you say gravid?
Yeah. So gravid just means pregnant, right?
Yeah.
So her uterus looks like there's something in it, basically. 2 centimeters below the umbilicus. Is that appropriate for her dates? I think she was 18 weeks pregnant.
I really have no idea.
It's okay. So it is. So the uterus at 20 weeks pretty much hits the belly button. And so hers is about 2 centimeters below. She's 18 weeks. That seems pretty appropriate. What about the non-tender part of it? What do you think? Why is that important to know?
Can you repeat that part? The non-tender part?
Yeah, so she has a non-tender uterus. So when you're touching, when you're pushing on that uterus, it doesn't hurt her. So why is that important to know? What were we thinking about that possibly can be going on with her belly pain that we would want to know about if it's tender or not?
Oh, the UTI.
UTI, yeah, but more specific, more importantly, like a pelvic inflammatory disease, right? So inflammation from a bacteria like an STI going into the uterus causing pain. So later on, like when women are in labor and delivery trying to deliver a baby, that would be something like chorioamnionitis. So basically infection of the fluid around the baby. And that causes inflammation of the liver. It gets very diffusely tender, and that's important to keep an eye out for. Anything else that can cause a tender uterus? And anybody can answer. It doesn't have to be just you, but I appreciate you trying. Dr. Linares is saying endometriosis, which, yeah, it can cause a tender uterus, but yeah, it's more chronic. She's pregnant right now, so she's not really menstruating. Torsion of you won't necessarily have torsion of the uterus. You can of the ovaries, but yeah. So Dr. Desai is saying miscarriage, right? So if you have a miscarriage and you're bleeding into that uterine cavity, if you have a placental abruption where the placenta, instead of being stuck onto the uterus like it's supposed to, starts peeling off and you're bleeding into that space, that blood is going to be very irritating to the uterus. And so you're going to have cramping. You're going to probably have some contractions. That uterus is going to be tender. Same thing with the miscarriage. So yeah. But the good thing about it is she doesn't have any blood that we can see. So. And then the other part of it is we're thinking abortion, but the heart rate is 150. The fetal heart rate is regular 150, so less likely that is abortion. All right, I think we got everything on the physical exam. I don't see anything else unless somebody else wants to bring something up. Yeah, we're good. All right, so let's go next. All right, so our differential diagnosis. So there's a ton of stuff here. So let's go one by one. All right. So at this time, which of the following differentials cannot be excluded? So what can we say? What can we say that is possible in this patient? I guess. So appendicitis. Are we saying that is possible? And you guys can all say yes if you think it is. So yes, 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 yes. Okay, cool. What about diverticulitis? People are saying no, probably not. It's possible. Can it be excluded? I would probably agree with you guys that it's uncommon for the age group. She's having regular bowel movements. Yeah, and it's bilateral. It would be weird if she had bilateral diverticulitis. So I would say we can exclude it. So I would click on the diverticulitis one. Or actually, I wouldn't because it's saying cannot be excluded. So I'm clicking on appendicitis, leaving diverticulitis out. Ectopic pregnancy. I think it's a little too late to call this an ectopic pregnancy. She's 18 weeks out. She's had regular OB visits, so I'm sure she had a ultrasound at some point. So I'll say that we can exclude it. Okay. Irritable bowel syndrome. Possible. She's not having diarrhea or constipation. So I'm going to exclude it, actually. I don't think that it's likely. And irritable bowel syndrome is not going to cause you to have a fever. It's not going to cause you to have nausea. Well, yeah, it can cause some nausea. Okay, so I'm going to leave it out. So I have appendicitis only so far. Pelvic inflammatory disease. What are we thinking there? You guys think it's a possibility? Yeah, I wouldn't exclude it either. She doesn't really have that discharge, but I wouldn't exclude it. So I'd keep it in my differential. placental abruption. So placental abruption is what we were talking about, where you have separation of the placenta from the uterus. It can cause bleeding in between, causes some pain. Yeah. If the cervical os, so if the cervix is completely closed, you can't get any blood out from there. So she can be bleeding into the uterus without any blood coming out. So I would keep it on my differential as well. Pyelonephritis. What do you guys think? Yeah, everybody's saying yes. I agree. I think pyelo is probably most likely so far. So it can't be excluded. What about sepsis? Do you think she's septic? Yeah, I think she's septic as well. Yeah, and then everybody on YouTube, I'm watching what you guys are saying too. You guys are hitting it on the nail as well. All right. Septic abortion. Do you think that's possible? So a septic abortion is basically you have an abortion of the baby. The baby inside has basically died, but it's contained, and now you have an infection in that area because of that. So there's something in the history. Yeah, people are saying no because the baby's heart rate is normal, so the baby hasn't died. So yeah, I would probably exclude that. Okay. Ulcerative colitis. So that's an inflammatory bowel disease. Do you think we can exclude that? Some people are saying no, some people are saying yes. Does anybody want to say why they don't think we can exclude it, or why they think that we can exclude it? This one's a little bit harder. Dr. Atreya, why do you think that you can exclude it?
There's no diarrhea or like any bloody stool or anything that would usually indicate something like that.
Yeah, it's not a super typical presentation of ulcerative colitis if there's no bloody diarrhea. So I would agree with you. I'd probably exclude it out. What about viral syndrome? Do you guys think that we can exclude that? Oh, and Dr. Linares said that ulcerative colitis is typically a chronic disease that seems acute. I definitely agree. The only caveat to that is ulcerative colitis at some point is going to present acutely. So, she's young. A lot of times you will have an acute presentation when you are young. So, yeah. And thank you for everybody who's explaining what pyelonephritis is. I appreciate that. So viral syndrome, just basically a virus, gastroenteritis, something along those lines. Can we exclude that? Probably with the CVA tenderness, I probably would say we can exclude it. But I guess if we're saying if it's possible, maybe not. I'm on the fence with that one. Some people are saying don't exclude. Maybe low on the list. All right, we'll keep it, and if we get it wrong, who cares? All right, and Zika virus. Is that going to cause nausea, vomiting? Is it going to cause her symptoms? I actually don't know. Zika, I think, has kind of non-specific viral symptoms, so maybe. I don't know if it causes vomiting like that, though. All right. I say it can cause some really bad headaches. So yeah. Gastroenteritis, orbital pain, travel history. Yeah. Okay. Yeah, we don't know. It doesn't. I don't know if we have a travel history on her. So I would probably exclude it. And if we get it wrong, whatever. All right. So I think we have our list. So we have viral syndrome, we have sepsis, we have pyelo, we have placental abruption, we have pelvic inflammatory disease, and appendicitis. So let's submit that. All right, so they're saying appendicitis can cause lower abdominal pain, so we got that right. So diverticulitis is uncommon for this age group, so you guys are right there. Ectopic pregnancy can very rarely accompany, although ectopic pregnancy very rarely can accompany an intrauterine pregnancy, it should manifest well before 18 weeks gestation. So yeah, good job, guys. IBS would not cause fever and vomiting. We said that as well. Although uncommon, PID can occur during pregnancy and cause significant morbidity. So cool. Placental abruption is not likely since the patient has no bleeding and her uterus is non-tender. Ooh, forgot about that. Her uterus is non-tender. So we got one wrong. Pyelo can cause fever and urinary frequency. Patient has significant fever, tachycardia, and systemic symptoms and should be evaluated for sepsis. Definitely agree. Although the patient has signs of possible infection, she has not passed fetal tissue and fetal heart tones are present. So basically the baby hasn't died, so it's not a septic abortion. And ulcerative colitis, no diarrhea or bloody stool that would suggest ulcerative colitis. Viral syndrome, numerous viral infections can cause fever, malaise, vomiting, and abdominal discomfort. So cool, we got that right. And then Zika, patient has no headache, muscle aches, or conjunctivitis, and abdominal pain is not a prominent feature in Zika. So we learned something. Cool, we did pretty good. All right, so any questions so far before we move on? Doesn't look like it. All right, let's go to the next. All right, so testing. Dr. Farida's asking for doing 2 cases today. I was planning on one. Sorry. All right, at this time, which of the following are the most important and appropriate initial diagnostic studies? So ultrasound of the kidney and the bladder, definitely. What about abdominal x-ray? You guys want to do that? Yeah, there's radiation involved. If we don't need to, we probably don't want to. So yeah, I'd probably leave that out. A BMP. So what are we looking for in a BMP? The kidneys, perfect. The creatinine, beautiful. So yeah, I want the BMP. All right, blood cultures. Do we want to get blood cultures on this patient? Dr. Polito, why do we want to get blood cultures on this patient?
Because we want to check if she's septic.
Yeah, so if she's septic, but what's important about blood cultures?
The white count or the white blood cells count.
Yeah, the white blood cell count will definitely be elevated if she is bacteremic. She has bacteria in her blood. The big thing with blood cultures is, I'm sorry?
Also, if she has any bacteria in her blood, maybe.
Exactly. And so if you have bacteria in the blood itself, so wherever the infection is, it's now seeding into the bloodstream, you're having it inside the blood, that can cause a lot of problems, especially if you're pregnant and you're circulating that blood to the baby as well. And so one is it can be harmful to the baby. You can have seeding of that bacteria into different parts of the body, and then two, it will also change the amount and duration of your antibiotics. So if you have just a regular, if you have a UTI, that's one thing. But if you're septic and you're bacteremic and you have bacteria in your blood as well, you're going to be treating that patient for a much longer time than you would for just a regular old UTI. So yeah, I would get a blood culture for sure. What about a CBC? I think a lot of you guys already said yes, because you want that white blood cell count. Dr. Deepika had actually a really good question. So if the mother's blood and the baby's blood are never mixed, could that still be a risk factor for the baby? Yes. And the reason why is not because the blood is going to the baby. That physiology is correct there. What my thinking was more, if you have a bacterial infection in the blood and it starts seeding into other parts, like at that interface in the placenta, you can form an abscess that can cause infection for the baby as well. there are also bacterial infections that can transfer toxins that can be passed through the placenta. Although the infections that we're going to be looking for are less likely to be that. So like actinomyces is one of them that is coming to thought right now. I can't think of anything else right now, but yeah. So it's more of kind of trying to see what we have and what we're going to be treating. But you're right. You're not having that direct transfer of blood from mom to baby. So good. All right. So people want a CBC. What about a CT scan of the abdomen? Yeah, exactly. You want to avoid as much radiation as you possibly can. Serum beta HCG. Is that going to be helpful right now? Probably not. We know she's pregnant already, so no. STD testing, do we want that? I think we want STD testing. Because it can cause, she can still have pelvic inflammatory disease, and it's still in our differential, so I would say yes, I would want to test that. Stool culture, she's not really having diarrhea, so probably not. And then urinalysis and culture. Yes, yeah, good job. We definitely want a UA and a culture. So we have UA culture, ultrasound of the kidney and bladder, STD testing, CBC, blood culture, BMP. Okay, good. I think somebody asked about albumin. I don't know what we'd be looking for in albumin. So if you want to explain what you're looking for, you can. I just don't know.
Yeah, I mentioned albumin just because it's typically used to like identify poor nutrition and kidney, I think, diseases. So I don't know.
So not so much kidney disease. A lot of times more liver disease, right? So the liver, if the liver's not working, your albumin a lot of times will be low. We see that a lot in cirrhotic patients. And then you're right. If you have very poor nutrition over a long period of time, you're not eating as much, your body's not going to have the building blocks to make that albumin, and so that will go down. So that's actually a good point. For her, she's been okay. If I remember right, it's been like 3 days since she was having these symptoms, and so she seemed okay before. She was gaining weight in her pregnancy, so probably less likely. But that's actually a good thought. I didn't think of that. So good. All right, so let's submit these and see what we got right. Okay, so plain X-rays do not help evaluate acute abdominal pain and would unnecessarily expose the developing fetus to radiation, so good job. BMP is necessary to look for evidence of electrolyte abnormalities and dehydrations, good. Blood culture to evaluate for possible sepsis, and I would probably say bacteremia instead of sepsis. CBC is not diagnostic, but the patient appears moderately ill with elevated, and an elevated WBC can be a sign of serious systemic infection. So yeah, I agree. CT is usually helpful in evaluation of acute abdominal pain. Other tests should be done first to avoid unnecessary radiation exposure. Serum beta HCG, patient's pregnancy is already confirmed, which we already said. STD testing is necessary to evaluate for a patient for gonorrhea, chlamydia, and trichomonas. Oh, I forgot about trich. Yeah, trichomonas is another important one. Stool culture, patient has no diarrhea, so not necessary. Kidney and bladder ultrasound is necessary to evaluate the patient for hydronephrosis, so good. We kind of said that. What is hydronephrosis? Does anybody want to tell us what that is? Fluid in the kidneys, urine can't drain. Dr. Steele, what is hydronephrosis? You kind of got it there.
So isn't it where the kidney kind of swells and then there's like a buildup of the urine that's stuck in there?
It's not necessarily the kidney. So the kidney is generally okay. If there's a blockage somewhere and that urine can't drain out, so your kidney's up here, your ureters kind of come down here. Let's say there's a blockage.
Okay, so it gets stuck in there.
Yeah.
Yeah, so
And
it can't go to the bladder then, right?
Yeah, and so what will
Got
happen is the outlet, so from the kidney down the ureter, it'll start to build up fluid and it'll start to swell and get more expanded, and so you'll see kind of a bigger caliber of your ureter going down, and the renal pelvis, that outlet from the kidney to the ureter, can get pretty enlarged as well, and so so that's what hydronephrosis is, and a lot of times it's because of a blockage. So good job. And then UA and culture, test for urinary tract infection should be obtained. Yeah, good. So, all right. So I think that is good. We basically got them all right. So let's go on to the next one. Okay. Oops. All right. So the test results. So hemoglobin is 12.5. White count is 17. Platelet count is 150. Sodium 137. Potassium 3.9. Creatinine 0.7. Glucose 78. BUN 23, her UA is there, and an ultrasound. So, who wants to take a stab at the CBC? I forgot who AKCSM was. Do you want to try that?
Yeah. My name's Shweta.
Oh, Shweta. Okay, sorry, Dr. Shweta. Tell us about the CBC. What are you seeing there?
So the white blood cell count stood out to me.
Yeah.
And it was pretty high. I'm pretty sure it's a normal. It's like 11,000.
Yeah. I'm forgetting the exact reference range values. I think it's 11, 12, somewhere in there. But yeah, this is definitely high.
In the chat, they're saying around like 4,000. Yeah.
Yeah, good. Yeah, if you guys want to put some of the values in the chat, that might be helpful, because I don't have them memorized either. I know what's abnormal and what's not generally, but okay, what else?
I'm looking in the chat right now. Someone said the BUN is a little high, which could indicate kidney injury.
Yeah, so the BUN is a little high. What about the creatinine, though?
I didn't really quite catch that part.
Creatinine's 0.7, so it's normal. Her kidney function looks generally okay right now, but the BUN may be a little bit elevated, but it looks okay. I wouldn't get too concerned at this point. All right, so hemoglobin looks okay, platelet looks okay, sodium, potassium, creatinine, glucose. Glucose is actually a little on the lower side, but she's not necessarily hypoglycemic right now. Yeah,
quick question.
Yeah.
So I know we've talked about before if creatinine levels like are higher based off of like a baseline. What happens if they're significantly lower? Like say maybe her baseline is 1.2 and she's down at 0.7. What does that typically mean?
That she miraculously had better kidneys. So a lot of times that doesn't necessarily happen. So patients that have like a chronic insult to their kidneys that isn't catched, maybe they can have a higher baseline and then it gets better. Or people that are chronically dehydrated, they can have a little bit of a higher creatinine count. But we typically don't see that where they're like 1.5 and then out of nowhere they become 0.7. Yeah, I don't think I've ever seen that. Okay, so her BMP looks generally okay. Her blood looks okay as well. Dr. Henning is saying the elevated BUN compared to the creatinine especially can show that she might be dehydrated, which is true. All right, Dr. Buchanan, do you want to tackle the urine? The UA?
Yeah. Oh, sorry. I'm looking at it on the website too. I don't know if we've actually gotten there yet. But it basically says that there's numerous bacteria in the urine, which indicates that it is probably like a UTI or some sort of bacterial infection, especially because one of the other higher things on our differential was a kidney problem, but we've seen from the creatinine and that it's probably not something that's super wrong with the kidneys. So we would be more leaning towards a sort of bacterial bladder infection.
Yeah. So perfect. So it looks like I'm just trying to pull something up here real quick. Okay, so with the UA, so the leukocyte esterase is positive. So leukocyte esterase is an indicator of urinary tract infection. It detects esterases contained in granulocytic leukocytes. So basically, the white blood cells have these esterases inside these enzymes inside of them, and it shows that there are more white blood cells in the area. So that points to an infection. Now, blood being positive, that can be a sign of an infection as well. The other thing, if you have somebody in with no symptoms coming in with bloody urine, you always want to be worried about like a cancer. So just keep that in mind. Although she has signs of an infection, so I don't think it's a cancer. So let's go through the rest. So ketones. So ketones are positive. So let me read what it says here. So I have my own interpretation, but I'd rather just give you what they say here. So ketones basically are, so the trace results may occur during physiological stress conditions, fasting, pregnancy, straining exercise. A lot of times when I see ketones, I think of maybe dehydration or starvation. But with her, she is pregnant, so that you can see ketones in the urine from pregnancy. Bacteria, there's bacteria in her urine, so that's great. WBCs means that there's infection or there's inflammation in the bladder. So seeing 30 to 50 is telling us that there is probably some type of inflammatory process going on. Nitrites. So nitrites are the one that I really wanted to talk about, because the nitrite test depends on the conversion of nitrate derived from the diet into nitrite by gram-negative bacteria in the urine when their number is greater than 10 to the 5th power per milliliter. So if there's a lot of bacteria in there. So this is a conversion of the nitrates to nitrites from the bacteria. So this is why organic chemistry is a little important in medicine. And it's important to understand this. And I guess not organic chemistry per se, but maybe molecular biochem. Anyways, this kind of goes back to that basic science. So these bacteria, especially the gram-negative bacteria, will tend to convert this. And so we've been able to develop this test to show if there's a bacteria, the specific bacteria in the urine that tells us that, yeah, they probably have an infection. It's a pretty good marker. And whenever I see nitrites, I'm like, oh, shoot, there probably is a bacteria there. Leukoesterase, positive, protein negative. So protein negative is actually pretty important. Although she's 18 weeks, above, I believe, 20 weeks, you can start thinking about preeclampsia and eclampsia. And so one of the hallmarks of those processes is protein in the urine. So good. And then the STD panel shows urine, gonorrhea, chlamydia, trick, negative. All right, so, and then the ultrasound. Renal bladder ultrasound showed no hydronephrosis, so that's good. Incidentally found noted intrauterine fetus with a heartbeat of 156 beats per minute. So we know the baby's alive, and there's no hydronephrosis, so that's great. Okay, any questions about the labs? That was a lot. So if you have any questions, we can go over it a bit more. Dr. Morgan on YouTube is asking, could she be diabetic? And she can potentially, but with these labs and glucose is 78 when she's not being treated with anything, probably not. All right, and I think that's all the questions I have here. Let me see. Okay, cool. No other questions? All right, let's move on.
Why was the protein important again?
So protein is important. One, because it shows that there might potentially be kidney injury. So if kidneys filter out protein. So when the blood goes to the kidneys, the proteins won't typically cross into the kidney area because that part of the kidney is, the pores basically are not big enough to allow that protein to go through. And so if there's damage to that area, you can start to spill protein into the urine. And so it tells us that there is kidney injury. Specifically for pregnancy, though, when somebody is pregnant and they have protein in their urine, that can be a sign for preeclampsia or eclampsia. And so patients that have very high protein levels in their urine, we do extra tests to see if they might have one of those. And so the other hallmark sign of it is high blood pressure, when they don't have blood pressure issues before. And so it doesn't look like she has that issue going on. And honestly, she's 18 weeks, so typically we don't see preeclampsia or eclampsia at 18 weeks. We usually see it later on. But it's always good to think about, especially if she came in, her blood pressure is starting to creep up. So good. And that's not her, but in general. Any other questions? All right. Okay, so the next part is asking, at this time, which of the following is the correct diagnosis for this patient? You may select more than one. And I'm sure all of you guys already know what it is. Can anybody tell me why they think it is their whatever diagnosis they're thinking?
I said that, okay.
Yeah.
I put that it was
I didn't catch that. You said it was what? Dr. Brown?
We determined that she has like the, I said the pyelonephritis and the, wait, can you hear me?
I don't know if it's just me, but I keep having it cut out.
How about now?
Okay, I can hear you now. Yeah.
Okay. So I was saying it was the first one, the acute pyelonephritis and sepsis. Specifically the first one because of the tenderness we felt like on both sides of her lower abs, and also the high white blood cell count. It's clear that she has an infection and her fever, and also sepsis because the presence of bacteria in the blood and also her white blood count, and so that would kind of give satisfy all the requirements for SIRS.
So she satisfies the requirements for SIRS. She has the elevated heart rate, her temp is elevated, and she also has the leukocytosis. Her white blood cell count is high. So she meets SIRS. We think that the infection is pyelonephritis, so she meets sepsis criteria, so we can call her septic. The but I think you said that she had bacteria in her blood. We don't know that yet. We don't have the blood culture back. We probably have to wait for that. Yeah, but pyelonephritis, so she has that CVA tenderness. She has, she's been having, so let's go in order. So she has nausea, vomiting, and lower abdominal pain. She has signs and symptoms on her labs on her vitals for an infection. So elevated heart rate, tachycardia and elevated temp, sorry. And then on her exam, she has that CVA tenderness. She has lower abdominal tenderness. No other signs of other infection, really. Labs show leukocytosis. Her urine looks dirty. Looks like there is an infection there. And then most importantly, her ultrasound is negative for anything else. So it doesn't look like there's a septic stone, because that's a completely different algorithm that you have to go through and treat. So why aren't we saying this is cystitis? So it's probably pretty obvious, but because it looks like it's infecting the kidneys, but cystitis is infection of the bladder. And so a lot of times it starts as a cystitis. One thing that I generally see in pyelonephritis versus cystitis is you have more signs of systemic inflammation with pyelonephritis because it's more inside the body cavity. It's less localized in one area. And so in cystitis, it's pretty local to the bladder, and a lot of times you won't really have that fever. I have a lot of people coming in with UTI with no fever. You won't really have a white count unless it's starting to progress. Versus pyelonephritis, typically you'll have an elevated white count, you'll have a fever. So it's kind of that idea of systemic symptoms, meaning kidneys are affected, versus local symptoms like the bladder. I don't know if that made sense, but for me, that's a pretty important distinction when I look at these patients. Okay, so, all right, let's submit this, and let's go through the answers. Okay, so we said it was acute pyelonephritis, and we said it was sepsis. Okay. So, acute pyelonephritis. So the patient has systemic manifestations, including CVA tenderness accompanied by indications of infection in the urine. So great. Appendicitis. Appendicitis can have moderate pyuria, so they can have white blood cells in the urine because of inflammation around the area. So if the appendix is inflamed, the appendix is pretty close to the bladder, so that can cause inflammation in the bladder as well. But you typically won't. But the patient's clinical picture is not really consistent with appendicitis. Cystitis is the infection of the bladder, which we talked about already. The presence of significant systemic signs plus CVA tenderness makes the diagnosis of pyelonephritis more likely, not just cystitis. Great. Nephrolithiasis, so stones in the kidney, or you can also have them in the ureter as well. An obstructing stone increases the risk of urinary infection. The patient's symptoms are not consistent with the stone, and there's no hydronephrosis or stone detected on ultrasound. So symptoms of a kidney stone are kind of like that colicky type pain as the stone travels down into the ureter, which doesn't seem like the patient has. And then sepsis, she is ill, has a fever, tachycardia, tachypnea, elevated white blood cell count, and has an impaired source of infection, so she qualifies for sepsis. Any questions there?
Yeah, could we go over really quickly one more time just the difference? Like, is the pyelonephritis the one with the kidneys? It says that that's like, it's not just cystitis, so is like cystitis a broader term for that? Or like just the specific difference?
Yeah. So cystitis is specific to the bladder, right? It's an inflammation of the bladder itself. Pyelonephritis refers to an infection of the kidneys. So a lot of times patients will have cystitis. They'll have a bladder infection that then travels up to the kidneys and causes pyelonephritis. And so you typically don't have systemic symptoms with cystitis because it's local to the bladder, versus pyelonephritis, it's more invasive. It's in the body. You're infecting the kidneys themselves. So a lot of times that is causing more of those systemic signs. So like the fever, the white blood cell count. Yeah. And so Dr. Steele's asking, so it's just an extension of UTI making pyelonephritis? Yeah, typically that's what it is. Okay. Cool. So any other questions? All right. Doesn't look like it. So let's go to the next one. So diagnosis of pyelo and sepsis is confirmed. At this time, the most appropriate management for this patient includes which of the following. So admit to L&D. So are we going to admit her to labor and delivery? Is she delivering a baby? No. So we're not doing that. What about admit to the medical floor? I would probably admit her. She's septic, so we want to treat her. Probably with antibiotics. Discharge home? No, definitely not. Delivery? No, she's 18 weeks. That baby won't survive. Normal saline at a 500 milliliter bolus IV. I'd probably give her fluids. I'd probably give her more than 500 cc's, but yeah, let's give her fluids. I don't know if that's the correct dosage. So ceftriaxone. So ceftriaxone is an antibiotic we can use for pyelonephritis. I'm trying to think if there's any contraindication to ceftriaxone in pregnant women. I don't think so. And the other ones I wouldn't give to pregnant women. So I'm going to say ceftriaxone is what we're going to give, unless you guys think otherwise. Dr. Steele's asking, wasn't she a bit dehydrated? So yeah, she was. So we want to give fluids. The question was 500, was a half a liter enough fluids for her? Or would she need more? I felt like she might need more, but whatever. So everybody good with ceftriaxone? Does she have a penicillin allergy? I actually don't know. Does anybody remember if she had an allergy? I might have just glossed over that. It's the one time it's important. No drug allergies, perfect. I'll trust you guys. Hopefully it won't kill the patient. Cipro, 500 orally every 12 hours. Cipro can cause tendinopathy in in kids. I'm trying to remember if that can cause tendon issues in babies as well, like in intrauterine. I think it can. So what happens? It makes the tendons more weak, and so you can have tendon rupture in kids. And so we typically won't give fluoroquinolones like ciprofloxacin, levofloxacin in kids. So I wouldn't give Cipro. IV dextrose, 5%, 1/4 normal saline, 75 mils an hour. That seems too low. I don't have a reason why we'd be giving dextrose. So, actually, Dr. Brown is saying she can't keep anything down. You're saying because of the oral medication. So yeah, that's actually very true. But I'm thinking now, does she need dextrose because she's not eating, and the dextrose will provide some calories? Probably not. So dextrose is just the sugar. The rate is too low, 75 cc's an hour. I probably want to give her more fluids now. So that's probably the wrong answer. But if she can't eat, eventually as she's hospitalized, I probably want to give her some sugar as well. Norepi, I don't know why we would be giving norepi in this patient. So yeah, so that's not right. And then tetracycline is teratogenic in babies, if I remember right. So I don't want to give that either. So, all right. Oh, Dr. Safa is saying it's a hypertonic fluid. So the dextrose 5%. Yeah. So that's also is it hypertonic, 5% dextrose? So basically what we're talking about is hypertonicity of the fluid. So how much stuff is dissolved in the fluid that you're giving. If there's a lot of things dissolved in the fluid that you're giving, and what can happen sometimes is you're going to increase the concentration of your blood as well, and that can have a ton of problems in your body. So what will happen is if you have a higher concentration in the blood, your cells are going to be at a lower concentration than your blood itself. And so the fluid inside the cells, the free water inside the cells, can travel from inside the cells to outside. And so your body's going to basically get a bunch of fluid from inside the cells out into your bloodstream to equalize that concentration. And that can cause a lot of problems with the cells. You can have like cell death and all that stuff. Yeah, you don't want to give hypertonic solutions if you don't have to. Dr. Zhao is saying my father had tetracycline as a child and had permanent effect on his teeth and bones. Yeah, so you have a lot of discoloration of the teeth. You can have a lot of problems with tetracycline. So it's not good for babies or pregnancy. Okay, good. So we have admit to the med floor, give fluids. So the IV normal saline 500 ml bolus, and then ceftriaxone. Good. Let's see if that's correct. Good. We got it all right. Admit to labor and delivery, no signs of labor, too early in the pregnancy for elective delivery. So admit to the floor, she has a systemic bacterial infection that is a threat to the pregnancy. She needs IV antibiotics and fluids until the infection is controlled. And she's able to tolerate oral fluids and drugs, basically what we said. Discharging home would probably be malpractice, so we don't want to do that. She can have worsening symptoms. She can't keep anything down, so she'll probably get more sick because she can't take her antibiotics. Delivery by C-section or induction, the baby won't survive. IV normal saline. She needs IV fluids beyond maintenance rate. So I agree. I just feel like 500 might not be enough. But it would depend on how she responds. Ceftriaxone. So broad-spectrum cephalosporin is acceptable initial treatment for pyelonephritis and possible sepsis during pregnancy. Ancef or cefazolin and cefepime are also acceptable antibiotics. Yeah, I would probably go with ceftriaxone, or actually maybe Ancef also is a good option. I probably wouldn't give cefepime, and that's just my style. I have an attending that would always tell me that there's three things. So he says, politics, fluids, and your choice of antibiotics. Everybody has an opinion, and nobody's generally correct. So that's your choice of antibiotics. Generally, is what you want it to be. And so, yeah, as long as you're not hurting the patient, it doesn't really matter. So norepi, she's not hypotensive, so she doesn't need vasopressors to keep her blood pressure up. And then tetracycline is contraindicated in pregnancy due to the risk of fetal malformation. Good. Oh, the IV dextrose. The patient needs IV fluids, but it's inadequate initial volume. All right, so let's go to the next slide. What organism is most likely the cause of pyelonephritis in this patient? And if anybody, I know we're been going on for a bit. If anybody needs to go for whatever reason, the rest of the video is going to be up on YouTube. So feel free if you have to. It's okay. So E. coli, Group B strep, Lactobacillus, Pseudomonas, Staph aureus. E. coli is probably the most common cause of UTI, and so I'd probably do E. coli. And the reason why you have E. coli in your stool, and so there's a proximity between the stool and the urethra, and so especially when people wipe from back to front, you introduce that bacteria into the urinary tract, and that can cause infection. So you never want to do that. So E. coli is the most common cause of UTI. Group B strep is typically you can have a infection, though it's not typical, but in pregnant women, you want to make sure they don't have Group B strep, and you test for that later on, because that can cause meningitis in kids when they're delivered. And so if they are Group B strep positive, before they deliver, you give them antibiotics. Lactobacillus is typical flora within the vagina. I don't think it typically causes a UTI. Pseudomonas is not a very common UTI. You'll see it maybe more in diabetic patients, which she's not. And then Staph aureus is a common bacteria, not really a common UTI. Dr. Linares has a very good point. So nitrites indicates gram-negative bacteria. Group B strep is gram-positive. Exactly. So, exactly. So the nitrites in the urine basically tell us this is probably E. coli. So let's see. All right. So yeah, so E. coli causes 63 to 90% of UTIs in pregnancy. Group B, and then they say nothing else about the rest. So great. Which group of patients should be screened? All right, this is the next one. So which group of patients should be screened for asymptomatic bacteriuria during pregnancy? So all pregnant patients, patients with symptoms of urinary tract infection, patients who had pyelonephritis in a previous pregnancy only, patients with symptoms of a urinary tract infection only. So I'm not asking you guys, because these are probably way more advanced than what you guys would typically be expected to know, but actually I should just shut up because everybody had the right answer. Yeah, all of those patients should be screened, because asymptomatic bacteriuria in pregnancy can cause preterm delivery. So it can cause the mom to deliver the baby earlier, basically. So you want to make sure that you check that there's no infection or no bacteria in the urine. So all pregnant patients, let's see if that's correct. Yeah, it's correct. So, all right, let's just go on to the next one. Which of the following are included in the criteria for sepsis? Somebody can answer this, because you all know.
Isn't it all of them except the respiratory rate? Is the respiratory rate over 20?
Yeah, so the respiratory rate over 20, temp is correct. Heart rate is actually incorrect because it has to be above 90, not above 110. So they're just being tricky there. White blood cell count above 12 is correct, and then the presence of an infection is also necessary for sepsis. So, yep, I think, yeah. So let's see if that's correct. So they're all right. Not the heart rate one. So it's going to be the temp above 38. yeah, so the tempo above 38, the white blood cell count above 12, and the presence of infection, the heart rate, like we said, above 110 is incorrect, and respiratory rate above 18 is incorrect. Okay, next. Cool, we finished the case. So, urinary tract infection is common during pregnancy due to urinary stasis, which results from hormonal ureteral dilation. So, I didn't know that. So, hormones in pregnancy causes ureter dilation, ureteral hypoperistalsis. So the ureters aren't moving as much as well, and pressure of the expanding uterus against the ureters. So the uterus is growing, and you're putting pressure on the ureters, making it harder for it to drain. So it's easier. So things that stay still or don't drain as well are nituses of infection. So you'll have you'll be more prominent to forming an infection. So asymptomatic bacteriuria occurs in about 15% of pregnancies and sometimes progresses to symptomatic cystitis or pyelonephritis. So about 15% of people will have bacteria in their urine and just doesn't cause anything, but you do have to treat it to make sure that they don't have preterm labor. So frank UTI is not always preceded by asymptomatic bacteriuria. So asymptomatic bacteriuria, UTI, and pyelonephritis increase risk for preterm labor and premature rupture of membranes. So we talked about the preterm labor part. Premature rupture of membranes means that the amniotic fluid sac, it ruptures early. That's when people say, "Oh, my water broke." That's what they're talking about. And if it happens prematurely, you're going to cause that person to go into preterm labor. That baby's going to be delivered earlier. And we never want babies to be delivered earlier because the more time they spend in the uterus, the better it is, up to about 40 weeks. Above 40 weeks, actually above 41 weeks is when we start inducing, because the risks of keeping a baby inside the uterus past 41 weeks are outweighed by the harms. There's higher risk of complications and fetal death. So up to 40 weeks, 40 to 41 weeks is kind of the time frame where we want to deliver. Past 41 weeks, we want to induce. All right. Treatment of symptomatic UTI is generally unchanged by pregnancy, except the drugs that may harm the fetus and must be avoided. And so I think they have a list here that some drugs with adverse effects during pregnancy, we can click on that and see. Oh, there's a lot. Never mind. Well, wait, actually. Okay, so there's a chart that says some drugs with adverse effects during pregnancy. Aminoglycosides is an antibiotics that can cause ear problems in the baby. So chloramphenicol can cause hemolysis, gray baby syndrome. So if you scroll all the way up, there's a little chart there. Let me see. Scroll up. You see where it says table 1, down more, down, where it says table 1 on the right. Sorry, I'm instructing my brother who's helping with the stream where to go. So scroll down a bit more. It's going to be on the right. It's going to be a red little box thing that says table. Yeah, click on that. Okay, so sorry. So fluoroquinolones causes arthralgias and musculoskeletal defects, impaired bone growth. No proof of this effect, which I actually didn't know. Macrobid or nitropyrantoin can cause hemolysis. Tetracyclines cause slow bone growth. Enamel hypoplasia, so you have that discoloration of the teeth, permanent yellowing, and then the enamel doesn't grow, and they have more susceptibility to cavities. And then trimethoprim increases risk of neural tube defects and due to folate antagonism. So when babies develop, if they're taking Bactrim or trimethoprim, sulfamethoxazole, it can affect the way that the neural tube and the brain develop, and so you never want to give those medications early on. There's a bunch I skipped over, but this chart is actually super helpful for not just antibiotics. But yeah, so that was the case. Any questions that anybody has? Did you guys like this format? Do you guys want to do more of this kind of solving together? It's fun for me because it's stimulating and it takes less time for me also. So yeah, you guys like the format? Okay. So we can maybe do this a bit more. I do want to keep doing. I keep wanting to provide you with cases, because when I make those cases, I make them with specific learning objectives, and I want to make sure that we get to those so that you're learning what I want you guys to learn, because I think that would be a little bit more helpful. Some of the stuff we talked about today is not super helpful right now at your level, and I'd want you to get more of that general idea. But I do like this format, especially if you guys interact. So we can do more of this if everybody likes it. Okay. Yay. Okay, cool. So, all right. So Dr. Frida is saying, I think the cases we've done helped us do this case a little. Yeah. So, all right. So for the next week, we're not going to probably do a case. What I want to do is, we have a lot of good experience within our group. We have a lot of people that are EMTs. We have people that are scribes. We have people doing research, people that are in combined BSMD and BSDO programs. And so I don't have all of that experience. And so I want to open up the floor to other people who have volunteered to talk to you guys as well. So I'll be here to moderate, and we'll talk about, some of the process. And I want you guys to come and ask questions. It's going to be open to everybody, so people in the class and people on the wait list as well. And so even if you don't necessarily have questions, if you're kind of already ahead and you don't really need that mentoring, what I would want you to do is participate and help out with some of the people that have questions. So as much as you can, I'm mentoring you. Try your best to mentor others in the class as well. And if you're in high school, that's great. You're going to learn about all the stuff you need to do early on. You'll be a bit ahead. Any questions about anything? No, not so much. All right. So with that, I will let you go. You're going to see more people in the Facebook group over the next few weeks, because I want people to start adding in. We'll probably use that to communicate a bit more along with the classrooms as well. And then also, if people have questions about medicine in general, you can post them in the Facebook group, and we can have people in the class in the group answer those as well. So that way, there's more of a collaboration and community that we're building. Cool. All right. Happy 4th of July to everybody in the U.S. And I hope you have time to spend with your family. Stay safe and take care. So for those who don't know, I put together a link tree, which we can probably put in the chat here and in the comments part, and actually the description. It's on my TikTok. It's on my Instagram. That link tree has all the links that I have here that I'm using. Links to the Facebook group, to Instagram, to TikTok, to YouTube. Sign-ups for one-on-one mentoring that I'm doing as I drive back and forth to the hospital. It's all full right now, but I'm going to add more dates, so just keep an eye out for that. And then if anything else comes up that we're trying to do, it'll be in that link tree. So one link to have everything in place. So yeah, cool. Thank you, Dr. Frida. If you don't mind, can you put it in the YouTube chat as well? That'd be awesome. All right. Take care, guys. Have a good day. Hope you guys stay safe. Bye.